So Miss Susan Tacky is admitted to the observation unit for telemonitoring. The reason why she's admitted, she has had about a week of unexplained episodes of dizziness, lightheadedness, pre-syncope, and chest tightening, which prompted her ED visit. Her basic labs and head CT in the emergency room were all negative. The EKG on admission showed normal sinus rhythm. You're told by the team that really there's nothing to do. Likely she'll be discharged and just have outpatient follow-up with her PCP. However, overnight you get a call from the tele that her heart rate has jumped to the 150s and she is feeling like she is about to faint.
Okay, Norma volunteered first, so we're going to let you go ahead and just tell us what you're thinking, what you see, and then we'll pass it off to Kiara, see if she has any other ideas, and then we'll get our experts to chime in.
Perfect. So when I was taught to read EKGs, the first thing I want to make sure is that the patient is in sinus rhythm. So so in lead 2, I see a P wave preceding I can see a P wave preceding the QRS complex, and the P wave is it's difficult for me to see in AVR, but the QRS complex is inverted. So and also due to the fact that this is a pretty rapid rate, it might be difficult to see the P waves. But I can see a little bit in lead 2. So I'm going to assume that this is in sinus rhythm, and this is sinus tachycardia. Honestly, just based on looking at that. In leads V2, V3, honestly, all the way to about V5, I do see hyperacute T waves, and it's difficult for me to assess if there's any sort of ST elevation just due to the rapid rate. But right now, what I can immediately see is sinus tachycardia, narrow complex, which means, and also hyperacute T waves within V2 to V4, which for me would be consistent with a possible arrhythmia located above the ventricles. So either within the atria or within the his not his bundle, the Purkinje, or the his bundle, sorry. And the hyperacute T waves could be indicative of acute ischemia.
Okay, I'm gonna pose two things you might want to consider in a description, and the first is regular versus irregular. Anytime you have a tachycardia, knowing regular versus irregular might help you. And the other is, does the rate give you any clue? So those are two things I want you to think about. Let's see what Kiara has to say.
So I'm nervous right now, but the first thing I learned previous unremarkable episode is that when I have any kind of arrhythmia, I have to assess if the patient is stable or not. So first, I would like to see if this patient have edemas or any crackles, if she or he has dyspnea, what about of his pulse, his oxygen saturation, if he or she had taken any other medications. And as she is on telemetry, I would like to see all her vitals. After that, I see this EKG. I'm not that good, I'm not sure, but this looks like in a frequency of 150, a little more than 150. And but this is a regular rhythm. So with that, maybe as I can see this is not narrow QRS complex, but it's quite narrow. So maybe I'm thinking about a supraventricular tachycardia too. And with that, I will assess about her past medical history, if she had any kind of valvulopathies, any previous arrhythmia, syncope, I believe I have heard about it, any pulmonary hypertension causes or pulmonary issues. And yeah, that's what I'm thinking about it.
So it seems to me like y'all have done a good job. Anne-Marie, I'm sure you've been called to see this before.
So kind of as alluded to, always look at kind of first the vital signs, because that's always my first triage point, is how quickly does something need to be done? Do we need to consider cardioversion? All those things. And so those are kind of the vital signs. But once, if the vital signs are stable, we have a little time to figure it out. We look at an ECG. As was mentioned, I'm looking at, is this from the sinus? Is it a regular, irregular rhythm? And then is it narrow or wide, are kind of some of the points. Anytime I hear a heart rate of 150, I have to think atrial flutter in a 2-to-1 pattern. And so I'm always kind of wondering about, could this be atrial flutter? And I have been fooled by atrial flutter before. I don't clearly see like the sawtooth pattern or anything that I would expect in a 2-to-1 atrial flutter pattern. And then kind of the other things I'm thinking about when it's regular are, is this just sinus tachycardia? Usually I don't expect sinus tachycardia to get above about 150 to 160. So if it's a lot higher than that, lowers my suspicion. Atrial flutter, is this some sort of SVT with reentrant circuit or an atrial tachycardia, are just kind of some of the things I'm thinking of with a regular narrow complex rhythm. I am having trouble seeing kind of clear P waves into, well, yeah. So I would be kind of wondering if this could be some sort of SVT pattern.
So that was beautiful. That was absolutely beautiful. When I see 150, I think of two things: 150 and regular. Okay, so we've ruled out atrial fib. Could be atrial flutter, but I don't see any flutter waves, and I'm looking really carefully. And you can get 150 with PSVT. And so the question that Mo had asked in the chat, does the clinical history help us? So go back to the clinical history, Mohit, because I think that may be a huge clue here.
Yeah. So one thing I didn't mention, and Travis asked in the chat, she is a 35-year-old female. So she is admitted to the observation unit, and the reason was for telemonitoring overnight. She's had a week of unexplained episodes where she described dizziness, lightheadedness, and chest tightness. So she was admitted for some type of pre-syncope and chest pain evaluation. Her basic labs, head CT, everything that they did in the emergency room were cold stone normal.
So that would definitely make me think about a supraventricular tachycardia with that history and kind of the sudden onset of symptoms.
So let's see if Norman Chiara, let's make the assumption for right now that it's PSVT. Now what do you do?
So if that's the case, or I guess our first indication would be to make sure that she's stable. Based on the presentation that we were given, she seems to not be hemodynamically stable, in the sense that she's feeling faint, she's feeling dizzy, she's feeling symptomatic. I'd like to know what her vitals are, and to go from there.
Can you help us, Mohit?
Yeah, absolutely. So her vitals, as everyone's asking, she's afebrile. Her heart rate is staying in the 150s. Her blood pressure is 100/60, when normally it is about 120s to 130s systolic over 80s, 90s diastolic. Respiratory rate is 24, and she's setting 89% on room air.
So, Chiara.
So,
What do you want to do? And this is a hard question. Okay. For both you and Norma, this is a very difficult question, but that's why we're presenting this as part of the Night Float series, because knowing what to do for this patient is a little bit more advanced.
so well, I can go first. First, what I'm looking at the EKG again, and I see a very big complex, QRS complex through B2 to B6, and I'm thinking with this left ventricular hypertrophy. And what I'm not thinking is what pathology can be causing this left ventricular hypertrophy. And with that, and with a very young patient with a pre-syncope chest pain, I'm really thinking about some sort of pulmonary hypertension, even a pulmonary cause or a cardiac cause. And with this, first I have to treat the emergency, which is the supraventricular or paroxystic tachycardia. And first, I think that first thing to do is assess with I forgot the word, a sinus massage or Valsalva. So this can be like the thing that can help her, and if not, adenosine. But with adenosine, I think this patient will have like a asystole, and I have never seen that, but I think that's like curious. So I will order labs, cardiac troponin, cardiac troponin, CK, some sort of renal labs, and a big labs, very a lot of labs right now.
Well, Mo had already told us the labs are normal.
Labs are normal. So
Labs are normal.
first of all,
let's go over this, because this is real. This is really, and then I'm going to tell you a story about a friend of mine. But let's see what Anne Marie, teach them how you would approach this, and we'll have Alonzo in the background and let him pipe in also. You're muted, Anne Marie.
Sorry. So when I'm called to the room in this situation, a rapid response comes overhead. I think the first thing I usually try to do after getting vitals is to just go ahead and get like the monitor and the Zoll patch and everything on, just in case things deteriorate. We have everything hooked up and everything like that. And then also that gives you another way to check the monitor, to see the rhythm, to see what's going on. And then in this situation, it's kind of, I'm using the ACLS tachycardia algorithm. Obviously, this person's alert, they have a pulse, so we're not doing the CPR, we're doing the tachycardia algorithm. And so kind of my first branch point is if they're stable or unstable. She has enough of a blood pressure that we don't need to think about synchronized cardioversion at this time. If the blood pressure was 80/40, I would be thinking about doing synchronized cardioversion. But right now, you know, I have time and I have maneuvers. So generally kind of the first thing after getting the pads on, usually this has already been done, but I ask them to vagal. And I usually demonstrate a vagal, and it's just really awkward, but I'm like, bear down like you're having a bowel movement. And then I do it and they laugh at me, and then hopefully they do it too. Another trick that the rapid response nurse taught me was getting a little syringe and having them blow into it, like blowing into a straw. That can also be effective. And usually I'll try both several times. There was a visual abstract that I saw. I wish I had like screenshotted it and tracked it down about like doing a modified vagal could help. I think it involved like some like lifting and repositioning and everything. I want to find it, but it was more effective than a regular vagal. So I'm going to have to track that down at some point. Then after that, usually I like make sure they have good peripheral access. If I think there's any chance their volume down, get fluids going and everything. And then kind of the algorithm would say if this is SVT to give adenosine. If you're giving adenosine, you should have the crash cart nearby, them hooked up to the pads and everything like that.
it's not fun giving adenosine. Recently, I've heard some people say like, oh, you can try a calcium channel blocker that may be effective. But kind of the classical thing is to give adenosine. I always, before giving it, I tell the patient that it's gonna feel like death for a few seconds, but thankfully it has a very short half-life. So it's kind of a transient feeling, but I do want to make sure that they know what's happening to their body. And so I make sure everyone's on board. I believe it's 6, and then if 6 isn't effective, to give 12. But sometimes in the room, if I just need to remind myself, I'll just like Google ACLS tachycardia algorithm to make sure I'm doing everything right. And then usually if I'm giving the adenosine and I'm not sure of the rhythm, I'll have the ECG on continuous, because then sometimes it will actually reveal if it's a really fast rhythm, it's actually atrial fibrillation, or it's actually atrial flutter that you just couldn't see because the rhythm's so fast. And then kind of those are the initial steps I do while quickly recycling the blood pressure and monitoring hemodynamics.
Alonzo, what do you have? Anything to add? That was pretty
That was
darn good.
outstanding. I have very little to add. The only thing I'll say is I'm probably the only person who loves giving adenosine. I know it's not super patient-centered, but the first time I did that as an intern with the ECG on continuous just blew my mind. The point Anne-Marie made at the end is so important. We get so into the algorithm that it's important to be able to revisit your diagnosis. So putting the ECG on continuous will, just think about what adenosine does. You basically can isolate what's going on at the atria, and you'll get beautiful P waves with no interference that you can truly analyze. So only couple of things I would mention is you want the IV as close to the heart as possible. So the more peripheral, sometimes the less effective it is. And then, just keep kind of moving up on the doses and try to capture the rhythm.
So, Mohit, what did you actually do?
Yeah, so we tried vagal maneuvers first, but those weren't really all that effective. A lot of times with vagal maneuvers and Valsalva, it's a user issue. As much as you try to make them do it properly, it doesn't get communicated well. As Anne-Marie mentioned, it can be a little awkward to do it in front of them too. So we ended up giving her adenosine 6 milligrams, and then once again giving her another dose at 12 milligrams. And there was improvement both in her symptoms and her vitals, and her heart rate went down to the 110s. So yeah, it was a quick resolution after we gave her the adenosine twice, and SVT is the diagnosis that we were going towards with that. So ultimately the resolution of her case is that we thought that she would benefit from seeing cardiology, because a lot of these patients have good outcomes after getting ablation for SVT.
So I'm going to tell you a story of a friend of mine. So I'm playing golf one Saturday, and I'm sitting down to eat lunch, which we do after golf a lot. And one of my friends tells me this other guy is in the locker room and he doesn't look so good. And I was the only doctor they could find. So I go in to see him, and he says his heart is racing, and he's sitting there doing carotid sinus massage on himself, which he'd learned how to do. This is a man who's in his 70s at the time. As I'm feeling his pulse, which is 150, and I got nothing. I got nothing right there. I'm getting ready to call the emergency service. He says, "No, I have this all the time, and I break out of it." As I'm talking to him, he's had this his entire life. He's even told a cardiologist, but it's never been documented. So they never knew what to do. After about 10 minutes, and he's sweating and he's kneeling down, and he really looks pretty miserable. But he had a strong pulse. I said, I'm gonna call EMS. He says, don't call him. I says, I'm pulling rank. I never do that. I'm with my friends, but I pull rank. The emergency services gets there in about 5 minutes, and they put on EKG, and we get this EKG. I said, okay, we got to send you down to the emergency room to get some adenosine or to get some DILT or something. Cause he'd already tried vagal maneuvers, and cause he was really well versed in all this. They're getting ready to take him away. And he says, oh, I'm back in sinus rhythm. And we do another EKG, it's perfect sinus rhythm. So I didn't make him go to the ER. I gave him those two things. I found him an EP doctor. He got ablation about 2 months later, and that was about 4 or 5 years ago. He's never had another episode. And he'd been in talking to his significant others, she told me that this was actually happening to him 3 or 4 times a week, and he would do it himself. Ablation is just for this, and I had a number of patients when I was doing outpatient medicine. Ablation is beautiful. To me, the big take home is 150 can be PSVT, it can be atrial flutter, and it's probably one of those two. And so every time I hear 150, I say, okay, this could really be PSVT. Is that right, Mohit, or am I just BSing?
No, I think you're spot on. The take home point that I wanted to take from this as well for all the learners is that when you have these paroxysmal events, not just in these arrhythmias, but any type of condition, any type of paroxysmal condition, there can be a long delay in diagnosis, like you're mentioning, because these episodes happen so infrequently, so erratically, that just like in this patient, when she presented to the emergency room, everything was pristine. So someone else in that scenario could have discharged her home and we wouldn't have caught this. She may have gone home, had it occur again, come back. And a lot of the times it's a fine balance of when do you decide this person needs to be admitted? When do you decide this person can go home? But just know that a lot of these patients, delay in diagnosis happens, and you have to take these situations and these symptoms very seriously when they occur like this.
So Travis is an emergency medicine expert, so he sees a lot of this. Travis, you've put a lot of good stuff in the chat. Could you just talk a little bit about how you handle this in the emergency department?
Yeah, so I would do everything that you guys had mentioned. I guess just over the years, you kind of practice with different medications, and you learn certain scenarios you need to do X, Y, or Z. And just what I found over time is I used to love giving adenosine. I mean, it used to be fun to do. And then like I found, hey, I can do the same thing with DILT. The only caveat is if it's a wide complex tachycardia, you don't want to give DILT in case it could be a WPW. But for the most part, DILT is safe. I'll give it in 0.25 mg per kg boluses in SVT. It works pretty well. You just have to make sure that they don't have CHF or they're hypotensive. It's really the only caveat to it. But you get the same result, and they don't get that feeling that they're going to pass out, or that feeling that they're going to die. It 100% is something that you should practice using both medications, because I think there's a place for both of them. But it's cool to know that you have more than one medication at your disposal for treating this. That's kind of my.
Yeah, and could you mention, you had something in the chat about the event monitor, and I've diagnosed a couple people with event monitors, but when someone comes in the emergency department and gives you this story and you're not going to admit them, when do you think it's worthwhile to get an event monitor, and when is that going to be too frustrating? I guess Travis is not going to talk to me anymore.
Oh no! Oh, I thought you were asking Ann.
No,
sorry.
You were the one who said event monitor.
Oh yeah. So I guess if the story, I guess one, it depends on their age whether if I'm gonna admit them or not. I mean, if it's an older person, and they have palpitations and you're not catching it. I mean, if they have depending on their medical history, if they have heart failure, CHF, coronary artery disease, the threshold might be lower to admit. But if they're a young person and they're 30, 35, 40, and they had an event of palpitations, and I don't catch it, they look well, their labs are normal, likely it's either, follow up with one of my cardiology colleagues, to see if it happens again. I mean, I guess a first time event, I don't know if I would essentially pull the trigger and say, hey, let's do an event monitor. But, if there's a history of it, and it's happened a few times, I think, probably higher yield that you're going to, find something. But I can't say that I admit, SVTs, if that was a question.
So I actually have had patients who had this like once a month. Then I've had other patients who could tell me when it was going to occur and knew what the triggers were for it. Those people are a lot easier to do an event monitor. I once sent someone home for 2 months with an event monitor. She never had an event. 2 months later, she finally had an event and showed up in the ER and were able to document it. But that's the key thing. And this is the story of my friend is if you can't document it, you can't get EP to try to fix it. They need to see an EKG that shows the PSVT at some point in time. So this is a great one, Mohit. And Kiara and Norma, do you feel like you know a little bit more than you did when we started?
Absolutely.
A lot.
Great job, everyone.
Before we move to the next case, Sal, don't throw up the EKG. I want to have a discussion before the EKG shows up.
Excellent. And if I could just add one point that's been mentioned briefly in the chat for this EKG and SVT in general, I think Travis and Anne-Marie already talked about the modified Valsalva. And the short background on that is the traditional Valsalva that we're taught had about a 15% effective rate. And there is a modified Valsalva that's been studied, as far as I know, only in the REVERT trial that had a 40% success rate, so much better. And that, Travis and Anne-Marie, correct me if I'm wrong, but a patient would blow into a syringe for about 10 to 15 seconds while they were sitting up in a bed, and then they'd immediately be lied down flat on their back with a 45-degree passive leg raise. And that would terminate about 40% of SVTs, if you guys ever hear about that.
It's perfect for the 35-year-old. It's not so good for the, morbidly obese 65-year-old.
Absolutely.
But it's really cool, Sal. Thanks for describing that.
That's awesome.
Okay, Alonzo the Great, or the other Alonzo.
The Hudibert the Lesser. But this is Mr. Maurice Mobitz, is a 42-year-old male marathon runner with a past medical history simply of hypertension, who's presenting to his PCP with polyuria, constipation, perhaps some mildly diminished exercise tolerance, subjective weight loss, found to have mild hypercalcemia on his BMP. Patient's kind of a VIP patient, wanted an expedited workup. So the PCP admits him to the floor for expedited secondary workup. He was kind of a late admission to the call team. This patient's handed off to you. He's getting some IV fluids overnight when you get a call for bradycardia, heart rate in the 40s while the patient is sleeping. The nurse was nervous. She woke the patient up, says he says he's asymptomatic.
I guess we'll let Kiara go first this time.
So, let's see. This is not an old man with polyuria, constipation, weight loss, and hypercalcemia. First thing I just came to me when I hear hypercalcemia, weight loss is, in example, multiple myeloma who tends to have hypercalcemia. Yes, this came into my mind. However, hypercalcemia can be due to many other causes. In example, if he has hypertension, I believe, he may be receiving thiazides. I don't know if I'm pronouncing well, and this can be causing a hypercalcemia. Some other causes of hypercalcemia can be other granulomatous diseases, adrenal insufficiency. I don't know right now, but if the main chief complaint is go with heart rate in 40s with hypercalcemia.
Yeah, so
And
time out, Kiara. The nurse calls you. The guy's lying there. His heart rate's 40. She wakes him up. He feels fine. His blood pressure's fine. So
okay, so
what do you want to do
well,
for the pulse of 40?
so he's a young, a marathon runner, and heart rate 40s at night. Maybe this will be good for him. Maybe this is normal for him. So I will check his heart rate eventually within the next days.
Okay. So Anne Marie, you're supervising Kiara.
Mhm. Yeah, so this is a pretty common scenario in the hospital. I think how worried I am about bradycardia depends on kind of the patient, their risk factors and everything like that. This is someone who sounds like they're in very good shape, which makes me wonder if this is just, you kind of hear about like the runner's pulse that's lower at baseline, and then our pulse drops even lower when we sleep. So a lot of times, kind of young, fit, healthy people will be bradycardic when they sleep, and it's not necessarily pathology, it's just physiology because they're conditioned and they have a young, healthy heart. So kind of usually in these situations, I think one question and one thing you have to realize is maybe, maybe it was just a pulse check at night, or maybe they're on telemetry, but in some of these situations, maybe, we are creating these situations for ourselves because we're maybe checking vital signs at night or putting someone on telemetry who doesn't need to be on telemetry, and then we kind of run into these situations and then we have to react to it. So usually in like kind of these situations, if the patient like woke up, was asymptomatic, had an appropriate heart rate, and was feeling well, you don't necessarily need to do a lot about it. If you're concerned or there's a little other pathology, you can get an ECG and see if it's sinus bradycardia. And if it's sinus bradycardia and he's otherwise asymptomatic and it was just when sleeping, I would say this is a natural response to sleep. If I have someone who's bradycardic and there's concern, sometimes I'll also walk them and see if their heart rate improves appropriately with walking, if they have a chronotropic response, because then that also reassures me that this is just a physiologic response.
So if I were being called, the first thing I'd do, Alonzo, is ask what the vital signs were when he was admitted.
So on admission labs, heart rate was low normal in the mid 60s. Blood pressure was fine, afebrile. Respiratory rate in the low teens, saturating on room air, completely normal vitals.
And so what I was doing there, Kiara, was this guy starts out with a lower heart rate than most 40-year-old men. It was a man.
Yep.
Marathon runner. I don't want to be presumptive. It could be a marathon runner woman. And starting out slow, you can get slower. And I will tell you that when I went to redo my privileges at the VA, they took my pulse and it was in the 40s. And they made me go do an EKG and to make sure that I didn't have heart disease. But I've been doing a lot of working out, and that's just that I get down in the 40s at night myself. So I think that I think that was everybody's instinct. He had a previous EKG that looked okay.
Interesting question, Dr. Centaur. So he got on the floor pretty late at night, and they just then realized that he had a order for an EKG. So since they had woken him up, they went ahead and got it. You can throw it up now, Sal.
Might as well look at it just in case, because I've known Alonzo since he was about 6, and he was sneaky back then, and he's still sneaky.
I'm working on it, guys. Give me one moment.
Oh, that's interesting.
You can read that, DB? Those are some young eyes.
I can see really well with my glasses off, close to the screen.
I love it.
Okay, Norma. EKG class.
Oh boy. um, I'm probably going to need some help. But so the first thing that I can see
We'll
is,
get someone to help you, but don't worry.
okay, perfect. So the first thing that I see, his rate is not regular. And I'm trying to see if it seems like there's almost grouping, at least in the lead 2 tracing. And I'm trying to discern if there's any PR prolongation, and I can't really tell. But the P waves are also not the same throughout the tracing. And then I see that there's also a dropped beat after the third beat in lead 2, and then after the fourth beat. So I'm worried for this patient. I'm thinking that this might be a type 2, a second degree type 2, but I'd like to know some more.
So what would cause that?
Lyme disease. Although Lyme disease would typically do, well, I mean, it can progress, but the first thing that I think of is Lyme disease, especially in someone who's young and he runs, and yeah.
Where is this patient from, Alonso?
Let's say he's from the great state of Missouri.
The great state of Missouri. Is there Lyme disease in Missouri?
Please say yes.
Not a whole lot.
Not a whole lot. There's I think the only Lyme disease you can get in Alabama is if you drink too much lime and you turn green. Okay, so Lyme disease could do that because he's around. I like that thought process. I never think of Lyme disease. Is that right, Anne-Marie? I have no idea. You're muted again, Anne-Marie.
Lyme disease can cause heart block.
Okay, so there are a lot of diseases that'll cause heart block. So we have to decide whether that's now. What I'm wondering about, because Alonzo is very sneaky, is this mild hypercalcemia have anything to do with it? Will hypercalcemia do anything to your conduction system?
Are you asking me or someone else?
Anyone.
I'm going to say yes, because yes.
So why doesn't someone pull up Google and look that up? Because I don't know the answer to it. So you know what you do when you don't know the answer, but because I'm worried about this hypercalcemia. Did this hypercalcemia cause this intermittent dropping of a beat? And what I'm trying to decide, if this was type 2, shouldn't he have prolongation before he drops a beat?
Ooh, let's have a discussion about that.
That's typically with winky. Oh, I can't pronounce it. I usually say winky banky, but it's the it's second degree type 1 winky bach that usually has the gradual prolongation of the PR interval. Whereas with second degree type 2, the PR intervals are unchanged, but it usually can happen in like a group type setting.
So Wenckebach, I think, is the right way to say it. Did anybody find out hypercalcemia and type 2? Okay, you can get shortening of the QT interval, Osborne waves, extreme hypercalcemia, but
is this patient on medications, maybe?
Question for me, he's just on some HCTZ. for his
What?
blood. Hydrochlorothiazide, I'm sorry.
Oh, okay.
Yeah.
Do
He's
we
speaking
get the
He's
degree?
speaking American slang, Kiara.
Yeah,
Do we
I
get
mean,
the degree of the hypercalcemia? One important point is HCTZ itself can lead to mild hypercalcemia.
Very mildly elevated, like 12.5.
so I,
12.5. So this is just an aside. If you see a calcium of 12.5 with hypercalcemia, check a PTH.
yeah.
Thiazide-induced hypercalcemia is so overblown as a cause. It's usually transient, but it will accentuate hyperparathyroidism.
All those labs are currently cooking.
So what do we want to do for this patient?
Well, as Dr. Hudebert already alluded to, we have some labs going for this patient already. The fact that he's asymptomatic, and I believe that we have him on telemetry right now. I think what I would like to do is do a physical assessment to actually see how he's doing, and to do a thorough past medical history and medicine reconciliation.
So let's go back to the hypercalcemia, because I think I know where he's going. I'm not 100% sure. So can you think of something that would cause hypercalcemia and interrupt the conduction system? So can we do a Occam's razor here? The hypercalcemia might be a clue. And you mentioned some causes of hypercalcemia, and one of them may be also be a cause of conduction abnormalities. Several people.
If this patient were from Peru, I will definitely be thinking about TB.
You'd be thinking about TB.
Yeah.
Okay, so he's in the U.S. So
Maybe sarcoid.
So sarcoid or histo, either one could do it, but sarcoid would be fairly classic for this.
Also, brucella or any granulomatous disease.
Right. So this would make us wonder about whether he could have a granulomatous disease, because Alonzo's presenting to us to this. If this was just admitted to us, would we think through this well? But because we're in this situation, amyloid syndrome could certainly cause the block, but it probably wouldn't cause the hypercalcemia. So I'm looking for Occam's razor. I guess this could be Hickham's dictum. So
what about multiple myeloma?
So how is myeloma going to cause the intermittent block?
Yeah, that's a good question. But if this have a compromise, like in an infiltrated disease, maybe this is some way that can be causing this.
So I guess we better go back to basics, right?
Yeah.
So what else do we know about this guy, Alonzo?
Dr. Centaur, since we're getting a little close on time, do we want to talk about the acute management of Mobitz type 2 block when you get a call overnight? You're hinting at the kind of fun I had with the case, but I want to make sure we discuss the bread and butter, meat and bones type thing that you need for overnight management. But you're locking in on me, Dr. Centaur.
Well, I was going to where the fun was.
Yeah, I think I made it too intriguing for you, but I just want to make sure we teach these fine young trainees a little bit about what's your level of concern with a Mobitz type 2 versus a Mobitz type 1. How do you tease those things apart? What do you do?
Anne-Marie, you have two learners here who are befuddled, and they call you up.
So a Mobitz type 2, I treat much more seriously than a Mobitz type 1. A Mobitz type 1 is generally a benign rhythm, but Mobitz type 2, you're getting deeper down into the conduction system, and it can progress into complete heart block. And so I generally treat it like a complete heart block picture, and would get cardiology involved, have them on telemetry, depending on kind of the pace and how slow it were. You might need to think about kind of like pacing, but you're going to need to be thinking about like pace, if they need a pacemaker, getting cardiology involved and everything like that, since it can progress to complete heart block.
Does that make sense to everybody? Okay, so we call cardiology, we get our labs. We're coming down to the finish line, Alonzo. Are you happy with that? Are you happy with that answer?
Yeah, I just wanted to, and Anne-Marie, as always, crushing it. I just wanted to make sure that we hammered the learners on the difference between a Mobitz type 1, a Mobitz type 2. Like Anne-Marie said, is a concern for risk of progression to complete heart block. These folks need to be admitted, need to be monitored. You need something between atropine at bedside versus pads in place, depending on how unstable they look. Quick reminder for the learners, Mobitz type 1, the way I remember that it's Wenckebacke is I think of one as W-O-N, like I won something. And I say Mobitz type 1 is Wenckebacke, and that warns you, meaning the PR slowly increases before you get a drop beat. So Wenckebacke 1 warns. Mobitz type 2, there's no prolongation of the PR. No progressive prolongation. It's just the drop beat. And this is, of course, the one that you have to worry about complete heart block. Because you were crushing it so well, Dr. Centaur, I feel like I do want to finish. So overnight, they put some atropine at the bedside. They reviewed medications. You always check your BMP troponins, make sure there's not ischemic disease. This is a young guy. It's not likely, but it is important to check. You check the TSH. You discuss the transfer to the ICU if he looks a little unstable. He was doing well, so he stayed overnight, atropine at bedside on telemetry. The next day, they obtained a cardiac MRI that was concerning for infiltrative cardiomyopathy consistent with sarcoidosis.
Yeah, 12.5 is too much to blame on hydrochlorothiazide. In terms of hypercalcemia,
VIP patient, David.
Don't get excited about thiazides causing hypercalcemia. It's on the list. Just don't get excited about it. 12.5 is not mild hypercalcemia. That's moderate hypercalcemia. That's you're starting to get the fact that he has polyurine constipation. And was it Norma who put in there that she immediately thought of hypercalcemia when she heard? Was that Norma or Kiara?
That was most definitely me. I love these labs.
But that's exactly the right instinct. And that means it's really significant hypercalcemia. You know, if it's 11, it could be a little bit of a lab error. 12.5 is probably not a lab error with those symptoms. And then the infiltrative diseases is what they're looking for. How is this chest X-ray? Does chest X-ray show anything?
You know, I don't have it in front of me. I'm sorry, Dr. Centaur.
I'm just wondering whether or not he had other signs of sarcoid. Cardiac sarcoid is really tough because it's really hard to really hard to treat. So, Norma, tell us the two most important things you learned today.
So I guess the very first thing that I learned today is the management of a Mobitz type 2. I knew that it could progress to complete heart block, but I wasn't necessarily sure like how that would be managed. And I think that for me, that was really important to learn. And then the other thing that I learned was that thiazide diuretics should not be blamed all the time for a hypercalcemia. If you see a hypercalcemia, don't immediately blame the diuretic. You want to get a PTH level.
Yeah. Or in this case, something else.
Chest X-ray.
Kiara, what are your take-home messages today?
If it is just to first, in the first case, that heart rate over 150, you just don't have to think about supraventricular tachycardia. Also, you have to rule out if there's an atrial flutter and give the correct management. And in this case, same as Norma, that you don't have to blame thiazides just for hypercalcemia. And also that there are other alternative for a paroxystic supraventricular tachycardia instead of Valsalva and adenosine. Now I learned diltiazem and the correct doses, so this is something I take too.
And Marie, other than the fact that you absolutely killed everything we asked you to discuss, what teaching points do you want to take from this for your learners when you're making rounds?
So besides not to trust Alonzo, just kidding. I think important things to remember are kind of assess the patient in the context of the patient and the vital signs and kind of what they're coming in for. I love the learning point about the heart rate of 150 to consider atrial flutter or SVT, because both of those can be pretty tricky to see on ECG and would different management than sinus tachycardia. And then also bradycardia. I think my favorite thing to do is if they're asymptomatic and not having chest pain or other symptoms and a stable blood pressure, is just to walk them and document their heart rate increasing, because it just makes me feel really good. And that's a free kind of intervention I can offer.
Although if they call you to see the patient at 3 a.m., they're not going to be too excited about going for a walk. But then you want to.
That's not necessarily a 3 a.m. intervention, unless you're taking care of a patient that likes to, stay up at night.
Mohit, what did you want us to get out of this that you thought we covered well?
Yeah, I think in this, always having the stable versus unstable in your mind first. I think that is the biggest takeaway for me. The other thing I was going to add is telemetry is your friend if you have it. If it is on the patient, make sure that when it's possible, go and look through all the telemetry strips, because oftentimes that can narrow your differential even further. So for the first case where it was an SVT event, if that patient's on tele and you saw that you weren't sure based on the EKG whether it was true sinus tach versus SVT, determining it, if you looked at the tele and you saw that there was a gradual increase over time to that 150, that might lead you a little bit closer to that this is a sinus tachycardia developing and something else is causing the sinus tachycardia. But if you saw that immediately there was just a 90-degree angle going up to 150 when initially the heart rate was fine, that then pushes you more into that PSVT scenario. So I think another takeaway that I would give for everyone is, if the tele is there, use it and learn to use it well.
Alonzo.
So first, I got to apologize. I smushed kind of two bradycardia cases together. I really am so glad we had the discussion about the healthy male or healthy athlete, male or female, with the low heart rates while they sleep. This is a call you will get on night float and you don't need to overreact to. I don't want this case to make you start thinking all these people are in problems. The second bit is sometimes I find that my learners don't realize how serious of a Mobitz type how serious a Mobitz type 2 is and how you do have to treat it aggressively. And finally, the coolest learning point for me was the modified vagal maneuvers, which as you can imagine on the Tinsley service, given the type of patients we have, it'll be very hard to find a patient that can do all of those things, but I'm very excited to try it the next time I have a SVT on the floor.
And we'll finish up with our outstanding scribe, the great Sal.
Thanks, Dr. Centaur. And I agree with Mohit. Never assume sinus rhythm if the heart rate is too slow or if it's too fast. Telemetry is your friend, and really most patients should get an EKG to confirm they're in sinus rhythm. I was also thinking, would it be helpful? Can you guys see my cursor if I pointed out the Mobitz type 2 changes on this EKG before we go?
Yeah.
Okay. So kind of looking at lead 2, the rhythm strip, that's typically the easiest place for me at least to see rhythm changes or rhythm issues. And I'm looking to see narrow complex, irregular. I'm looking to see P waves and if they're conducting. So you see P wave conducted, P wave conducted, P wave conducted, P wave dropped. So looking at this sequence, I'm paying specific attention to, is the PR interval getting progressively longer before the drop? And I don't see that. If I did, I'd feel more comfortable with Mobitz 1, but because I don't, it's enough for me to ask for help and ask for another person to lay eyes on this EKG to make sure they're not in Mobitz 2.
Great. Thanks, everyone. I hope you got your money's worth. You didn't pay anything, but you did spend an hour, and hopefully you got good education from it.